All right, so we're going to finish up our cardio discussion today, and then we'll move into pulmonology. And I think if I can finish Pulm Part 1 and 2, we'll be back up on schedule, so we'll be good to go. Anywho, any questions from last time that we met? Nothing at all. Okay. Oh, just a bit of housekeeping as well. Unfortunately, I was looking at the review that I had for EpiBio, and the questions themselves and like the answer are too wordy to really do a Kahoot with. So I'm going to do like a narrated PowerPoint that I'll post up. You can kind of do along with me. The answers will be in the like little note section at the bottom. So if you want, kind of go through it with me if you're watching the video, or try to answer them beforehand, see what you think, and then I'll go through like the discussion and everything like that. That should be posted up by Monday, so that will be there for your review, and then the test is on Friday, correct? That sounds about right. So, okay. Anyway, going forward, our antiarrhythmics, and remember, how do we classify our antiarrhythmics? So you have 1A, 1B, 1C. What classifies a 1 versus a 2 versus a 4? The mechanism of action, right? So specifically how they're working as an antiarrhythmic, and how we're going to be dividing these up. So the class 1s do what? Sodium channel blockade, right? And again, are those going to be good just for atrial arrhythmias, ventricular? What do you think? Both. You can use them for both in these cases, as we'll see. And we talked about the 1A. How do you remember the 1As? Pretty darn quick, right? So PDQ is how I remember it. That's procainamide, disopyramide, and quinidine, okay? Those are going to be acting on the sodium channels, usually in the activated sort of state. So once it's kind of open, that's when those are going to kind of jump in, bind up that sodium channel. Remember, what did that do to the action potential? I thought to extend it out. Remember, it was one of those things where we're altering the refractory periods, right? Remember, there's an absolute refractory period, which means what? Yeah, nothing cannot come through and initiate a new action potential. But if we also have that relative refractory period, which is what? Yeah, a strong enough impulse can come along and re-trigger off that action potential. So for instance, if we're able to elongate that action potential, we kind of lengthen out that absolute and the relative refractory period, making it more difficult, more difficult for something like a reengine arrhythmia to come through and then start to make an ectopic foci, right? So due to that, that's why we like the 1As, because they're able to extend that action potential. What the big difference here with the 1Bs is they actually work to shorten up phase 3 here, and this is because they have more of an affinity for the inactivated sodium channel. It's pretty rapid that it's going to dissociate off from that channel, but what's interesting is that this works better and has a higher affinity for ischemic tissue and has relatively little effect in normal heart tissue. So who might this be important in? Perhaps someone who's had some ischemia, like an MI, right? So again, if you're having someone who's developing, say, ventricular arrhythmias due to an MI, or perhaps you forgot to ask allergies before you were to give a medication for someone with an MI and they go into a code. Did anyone have that happen recently to them? It's a very good point, though. Very good learning opportunity to always remember to ask allergies before you give a medication. Anywho, not to bring up past traumas, but again, it's good to reiterate some points and try to make sure we remember those. Anywho, but this is good because you're going to find these have a little bit more activity at the ischemic tissue, which is oftentimes where the kind of the problem is, right? Because that's where you're having the altered electrochemical activity there that is going to be, so aberrant compared to the normal healthy tissues. Good thing. The one main drug you're going to see in this category that I'll mention here is going to be lidocaine. Now, does anyone know what else we use lidocaine for? It's a local anesthetic. Well, how does it work as a local anesthetic? Same way it works as an antiarrhythmic. It blocks sodium channels, right? So sodium channels are good for not only propagating action potentials in the heart, but also in the nervous system, as you remember from our time in physio, right? Hopefully everyone remembers that class. But anyway, so by blocking sodium channels, you can inhibit that propagation of an action potential. If you do that in the nerves, you can have pain being inflicted to, say, a laceration, say, on the hand, but that signal never makes up to the CNS. We'll talk about those later on in a different part of this class. That's how it works as a local anesthetic, but here we're using it as the sodium channel blockade to try to treat some of these arrhythmias here. And so some of the cases you're going to see this being used are going to be, say, ventricular arrhythmia secondary to MI. We can use it for things like VFib, VTAC, Wolff-Parkinson-White. There's a couple of different places, but typically the more ischemic of the tissue you're dealing with, the better affinity lidocaine is going to have for that. Now, you will notice that lidocaine does not get used very frequently as an antiarrhythmic anymore. It's kind of been supplanted by some of our class 3 agents we'll talk about just a little bit later, but it's good to have some exposure to it because it goes to show you, like, imagine if you were treating someone, you're giving them lidocaine as a local anesthetic. Well, what would happen if I maybe gave too much of it? That too much was getting systemic. What other effects might you expect to see? Effects on the heart, right? Because we're talking about as an antiarrhythmic, and what do we say about antiarrhythmics? They can cause arrhythmias. Yeah, so cardiac toxicity is a big problem you're going to see with a lot of these local anesthetics, because it'd be nice if they only affected the nerves carrying these painful signals up to the CNS, but they're also going to work on the heart as well. And so cardiac toxicity is a big thing you worry about. And so if you deal with a lot of local anesthetics, you'll kind of get a feel for that. But just goes to show you that, again, depending on how we're using this drug, sometimes it can be a beneficial effect in the case of an arrhythmia, or it could be actually causing negative effects, causing toxicity, causing an arrhythmia, as the case may be. Now this one has to be given IV, mainly because it has a pretty heavy first pass metabolism here. So we will typically use this as a continuous infusion. We're going to administer it. Again, we can titrate our dose based on the patient response, depending on what the rhythm's doing, what the heart rate's doing there. And so, again, it's going to be good in cases where you have that ischemia, where you know that's kind of one of the mainline issues you're dealing with in your patient there. Not great against atrial arrhythmia, so this one's going to be more relegated down to the ventricular ones. But again, we're not using this quite as frequently anymore as an antiarrhythmic. We'll talk about some other agents that are getting used more commonly now. Now, other toxicity you're going to see, we know that it affects the CNS, because it's going to be affecting those nerves and propagating action potentials. We can expect to see some effects on the CNS as well, so things like drowsiness, confusion. This can be leading all the way up to things like seizures developing here, and oftentimes if they start to develop nystagmus, that can be kind of an early sign of toxicity there, right? And nystagmus is what? Yeah, kind of just jerking of the eye there. So again, if you're seeing like horizontal nystagmus, as you're having them follow your fingers kind of beating there in the corners, that can be a sign that they're having some issues developing. Again, some patients are going to have local anesthetic toxicity. Lidocaine can be one of those that can precipitate that, so just be aware. If they say, oh yeah, I got some anesthetic one time, I had a bad reaction, try to elucidate further and try to see what specifically their issue was, and it may be related to lidocaine, as you'll see there. And just be careful if you're dealing with patients with organ dysfunction, particularly hepatic dysfunction. They cannot metabolize the drug as quickly, and they're going to hold on to it longer, so you may need to give a lower dose in those cases. Okay, so moving on to the 1C, this is going to be another kind of broad category as far as actions go, as far as working for both atrial and ventricular arrhythmias. We have the 1Cs. These are going to be working to prolong that refractory period, kind of similar to what we saw with the 1As. But again, they're going to have a little bit different affinity as far as the channels and how quickly they're going to be dissociating. Here we see that they work on the open channels, but they're going to dissociate pretty slowly here. So again, they're going to be good for treating. We use these a lot for atrial fibrillation if you're going to try to go for rhythm control. Remember, when I say rhythm control, what does that mean? Trying to put that patient back into a normal sinus rhythm as opposed to just controlling the rate that goes on. Because what's the issue with having, let's say, AFib? It's an irregular rhythm, but what is it? What do we worry about? Because again, the atria aren't really contingent on getting good blood flow out of the heart, right? Those signals are going to propagate down to the ventricles, right? And so that's where you run into issues. The more that conduction occurs, especially with the aflutter, you can have very rapid conduction there. And so if the ventricle is not going to be pumping effectively, that can be a problem. So what we can do is by giving something like a beta blocker and slow down that conduction from the atria down to the ventricles, that oftentimes is a better way to control that. And that's going to be called rate control, where you're just looking at the rate of the heart as opposed to trying to get the patient back into normal sinus rhythm, right? So you can leave potentially a patient in AFib, or especially if they're kind of intermittent in and out of it, you can leave them on something that's going to just control that rate. And that's one thing, versus putting them on drugs that are going to chemically convert them over to normal sinus. Kind of keep that back in mind. We're going to talk more about that in a second here, but that's oftentimes what you're going to see with these 1C agents here. So anyway, so looking at these, one of the big ones we have is going to be flecainide. And so this one's going to be blocking sodium channels, as I mentioned. Another action it's going to have is to block potassium channels. And if you remember, blocking potassium channels is going to do what to the cardiac action potential? So shorten it, prolong it. It's going to prolong it, right? Because when do you worry about potassium and the action potential there? The efflux on the repolarization aspects of it, right? So again, if I prolong that, if I slow it down, that's going to elongate that refractory period as well, right? So it's going to slow that down, that process down. And so by doing that, it's going to prolong kind of all intervals on the EKG, the PR, QRS, QTC, all that's going to be getting prolonged there, because not only affecting on the sodium side, but also on the potassium side as well, as you can see. This one has a pretty long half-life, so we give it orally pretty frequently out there. And in some cases, we actually will use it to help control PVC. So if a patient is kind of prone to that, this is one drug you may see being used for that. Again, our indications mainly going to be for usually life-threatening ventricular arrhythmias, supraventricular arrhythmias especially. You can use this for the atrial control there. And so we like to use this in patients kind of without significant structural damage to the heart. They tend to be a little bit more sensitive to the effects, and you can again see some arrhythmias. These can be potentially really dangerous drugs if used inappropriately, so you got to be really careful and kind of judicious about who you're going to be using it in. These are not the drugs you're going to be prescribing to patients routinely unless you work like with cardiology. But if you see patients who are on these, you at least want to be aware of kind of what their actions are, kind of what the potential dangers are going to be with them. As far as toxicity goes, again, if you induce VTAC secondary to this sodium channel blockade, it can be very difficult to treat. So for instance, I remember I had one patient got called to the poison center as a young guy, had a congenital heart defect, but he was on flecainide for control of his arrhythmias. He had a host of other kind of medical issues, but he decided he wanted to harm himself and decided he wanted to end it all. And so he went ahead and took all of his flecainide all at one time. And that was one of the really difficult patients to manage. Unfortunately, he ended up dying at the end of that. But again, when you think about these drugs blocking up sodium channels, how do you think we could treat that? How do you think we would reverse that? We have to get something that kind of unblock the sodium channels, and so we can try doing that by giving like a lot of sodium, right? So for instance, we give them something like sodium bicarb, try to overload those channels and try to kind of kick the drug out, so to speak. But it can be very difficult to treat arrhythmias, and like I said, that patient unfortunately succumbed to that overdose there. But anyway, again, I know you guys are already in a really good mood for being here for 4 hours, so I don't mean to darken the mood any further, but it just goes to show you these again can be pretty dangerous drugs you want to be tangling with here. Anyway, some other problems we can see with this, potentially bronchospasm, seizures, especially if they're not clearing the drug effectively, things like that. And in fact, in some cases, especially from a rhythm control aspects, patients with MI, previous MI, tend to have a higher mortality with this. This is why you don't see these drugs used too frequently. There might see some older patients who have been kind of or like legacy patients who have been on it for a long time and have not ever gotten off of it. The other one in this category is going to be propafenone. So really the two big ones you're going to see in the 1C are going to be propafenone and flecainide. This one actually has a little bit of beta blocking activity as well, which is why it can also be somewhat useful for atrial arrhythmias because it can kind of help slow down that conduction between the atria and the ventricles there. Again, any of these are going to be pro-arrhythmic. Obviously, if you're blocking beta receptors, also what do you have to worry about? Not only in the heart, but where else do you have to worry about beta receptors? In the lungs, right? So asthmatic patients will not be a good drug for them because of that. Again, a host of blood dyscrasias that can happen with this. So again, not used too frequently, but you still may see some patients who are on this. Why do you think you can see worsening CHF? So you're blocking beta receptors. What does that do to cardiac output? It's going to knock it down, right? So again, that's not good for CHF patients who are requiring this the cardiac output. Good. So those are the 1Cs. Those are kind of the main sodium channel blockers you're going to be seeing there. Again, as far as frequently how often you're going to see those are going to be much more kind of specific use cases. You're going to see that, especially like, procainamide, disopyramide, flecainide, all those things. They're going to be used a little less frequently, but again, very specific use cases there. We'll use it occasionally for some of our kids that have like congenital heart defects. Maybe they have then kind of conduction abnormalities. We'll use propafenone occasionally. We'll use flecainide occasionally. So again, there are some special use cases for it, but not used as frequently. Kind of the rest of the ones we're going to talk about from here on out, as far as antiarrhythmics goes, are used much more frequently. Okay, so for instance, class 2, we have the beta blockers, right? What's going to fit into this category? Metoprolol is a good one. Carvedilol is a good one. Bisoprolol, propranolol, any of those beta blockers could be potentially used in this category here. We're going to talk about one of them specifically is going to actually fit into category 3. So we'll talk about that in a few minutes here. But what are these doing? Blocking the beta receptors, obviously. They're slowing down conduction. And what is that going to do to the heart? It's going to slow it down, right? So again, we're decreasing the automaticity here. What type of arrhythmias is this going to be good for? Supraventricular arrhythmias, right? Is this going to do anything to an arrhythmia that's developing in the ventricles themselves? No, right? So again, if you had a patient who's developing, say, an MI, inferior wall MI in the ventricles, and you have an arrhythmia developing from that due to that that altered electrophysiology in that tissue there, a beta blocker is not going to do anything, right? And in fact, you can actually make it worse because if you want that conduction coming from the atria, you want those to take over, right? Because again, that should be the fastest kind of the AV node. The SA node should be setting the pace of the heart, so to speak. So again, if you're lowering that, if you're slowing that down, it's actually going to make those ventricular arrhythmias potentially worse. So again, these are only going to be good for supraventricular arrhythmias, okay? Again, there's one notable exception that goes into class 3, so we'll talk about it in a minute, but just be aware of that. Again, we're going to prolong the AV conduction. We're going to be decreasing that phase 4 depolarization, and overall just kind of slowing down the heart. Good for SVTs or supraventricular arrhythmias. Anyway, just to give you a couple of ones that we would use pretty commonly, propranolol is a good one. Now again, non-selective beta blocker is kind of the prototypical sort of beta blocker you think of this from a non-selective sort of standpoint here. Again, another kind of benefit of propranolol has some membrane stabilizing activity, which can be good from an arrhythmia standpoint, kind of help to decrease some of that kind of, sometimes that tissue can become kind of aggravated and kind of more likely to develop those arrhythmias, and kind of help to stabilize that a little bit and prevent it from kind of propagating itself. But good for suppressing things like PVCs. Again, be aware though of the negative chronotropic, the negative inotropic effects there. If your patient's really dependent on that cardiac output for things like perfusion with CHF. Again, most often as supraventricular arrhythmias, PVCs, MI. Obviously, we would use that pretty frequently. But again, what kind of MI patients would you not want to use propranolol in? They're already hypotensive, they're already bradycardic, right? Those are things you want to think about, right? So again, you think beta blockers are good for MI, but you have to think of the actual clinical situation at the time. Again, if they're coming in, they're tachycardic, hypertensive, that's a great patient for a beta blocker, right? So you can think about those sorts of things. And obviously, we already know about the toxicities with this. We know about the worsening heart failure, the hyperglycemia. We know about the CHF, all of that. So again, I'm not going to belabor those points, but just make sure, again, review all those things, because you can use beta blockers now for arrhythmias, CHF, or angina. I mean, they get a lot of use here, so be kind of familiar with their toxicities. Metoprolol is another good one. Acebutol is another cardioselective one you may see used occasionally. Metoprolol is probably used more commonly. If you think about in the hospital use, I see that one used quite frequently IV for either management of blood pressure or potentially here as an antiarrhythmic. But again, big benefit of them being beta-1 selective is what? I don't have to worry about my asthmatic patients, right? So that's going to be the big thing with that from that standpoint there. The other big one I see used pretty frequently, especially for kind of like really short-term kind of acute blood pressure management, is going to be one called esmolol. This one's going to be given, usually like metoprolol used kind of intermittent dosing. I may give a dose every few hours or so. With esmolol, it's actually given as a continuous infusion. It's called Brevibloc is the brand name because it's very short-acting. So I can give a bolus, get the patient's blood pressure, heart rate under control, and then I give it a continuous infusion, and that way I can dial it up or down based on how the patient's responding. So you see that being used in like an ICU or like an ED setting with some regularity there. But again, what's the benefit of like a really short-acting drug like that I have to give via continuous infusion? What happens if the patient becomes toxic? I can just cut it off at the baseline, right? So again, they can either dial it down a little bit, but if it gets too much, then I can just cut it off. With other drugs I'm giving intermittently, once I give that dose, can I do anything about it? Like I play the waiting game at that point, right? So again, that's why especially when you have really acute sort of tenuous patients, having short-acting drugs like that can be very beneficial, because again, the sooner it's out of the system, the sooner the effects are going to be gone, right? Okay. So again, remember, any of those beta blockers can fit into that class 2 sort of category, so just know that's kind of how we're going to be referring to those. Class 3, though, this is more of a unique, this is where we're going to be introducing some of the newer drugs here. These are going to be potassium channel blockers, okay, which means these are going to be prolonging the recovery phase here, this repolarization that occurs here and extending out the whole action potential, right? So again, we're going to be seeing prolonging, in particular, what interval? The QT, right? Because again, that's measuring how long that repolarization is taking here. So again, QTC prolongation is going to be the big thing you're going to be noticing with these ones. So probably the biggest one you're going to see here in class 3 is going to be called amiodarone. Right, one patient came up and was asking for a refill of his amiodarone. That took me a little bit to figure out what that he was talking about, but his amiodarone is what he's actually referring to. And this one is a very good drug. It is used orally in IV. Of course, in my setting, I see it's used a lot more in the IV setting to control acute ventricular arrhythmias. It's actually an analog of thyroid hormone, which will be important for some of the toxicities we're going to see here in just a few minutes. But it's a very, very long half-life, around 40 days or so. So based off of that, a half-life of 40 days, how long would it take to get to steady state? See, 40 times, what, 5? 200 days? Like, that's a little too long, right? We don't have really time if we have a patient with a ventricular arrhythmia. So what do we do to get around that long half-life to get to steady state? Loading dose, right? We're going to give loading doses or a big bolus dose to try to get them up to steady state initially. So when you look at, and especially when you get to ACLS in the summertime, you'll see that you're going to see amiodarone. We give it as a bolus initially, and then you follow it up with a continuous infusion afterwards. Because again, that bolus dose, that loading dose is to get them up to steady state, and then you have to give them something to keep them at that steady state. And otherwise, what's going to happen to that arrhythmia? As the levels of the drug drop down, it could come back, right? So again, they could see, the arrhythmia come right back as soon as those drug levels drip down below that critical point there. So again, that's why we require loading doses on those. Now the class 3s can also be used for atrial and ventricular arrhythmias, and especially in the ER setting, we're going to see these used for any of these. We use these for, say, for instance, supraventricular tachycardias that are, say, unresponsive to other medications. If you have a patient who's coding as VFib, VTAC, this is the drug we're going to be using for them. If you looked at the ACLS guidelines from years past, you see lidocaine or amiodarone could be used potentially for ventricular arrhythmias. Nowadays, lidocaine is used as kind of a backup agent if amiodarone fails. So this is kind of the go-to ventricular arrhythmia drug that we're going to be seeing with those patients, right? Now, of course, it doesn't replace necessarily electrical defibrillation, but this is the chemical way we can do this if a patient maybe is resistant to shocking or if they're not a good candidate for that. But anyway. And again, we're using these pretty frequently. It's kind of replacing lidocaine and MIs for these patients. It's a very, very effective drug. So other actions it's going to have here, as I mentioned, potassium channel blockade is going to be the biggest thing you're going to be seeing with this one, but it's also going to help to inactivate some of these sodium channels. It's going to help to block some calcium channels, so it's going to help with some contractility, help down with the automaticity there, block some alpha and beta receptors. That's a lot of actions you're going to see here. So overall, what you're seeing is you're going to be decreasing automaticity, decreasing that conduction, and then prolonging that refractory period. And that will give you a long enough refractory period so that way if you have a ventricular arrhythmia that's trying to propagate there in the ventricles, it'll kind of get blocked off and can't really propagate itself any further because those cells are still going to be in that refractory period. It cannot be triggered off again due to that prolongation there. Does that make sense? Anyway, so toxicity, the main things you're going to see with amiodarone is hypotension can be a big one, right? Because again, if you're using this as a cardiodepressant, obviously heart blood pressure can go down because of that. Some of the more chronic things you can actually see, and this can be some of the side effects you'd be seeing over years if patients are maintained on this long term, could be things like a pneumonitis or pulmonary fibrosis. It could be potentially fatal in some patients. And again, this is over the course of many, many years. You'd see that develop. We do have some muscle toxicity. One of the kind of interesting things is you can develop this kind of blue-gray skin discoloration that occurs over many years as well. Kind of the drug kind of gets deposited or something gets deposited, causes kind of discoloration. So you may see that, corneal deposits. And then interesting with the thyroid, you can either see hyperthyroidism. So maybe potentially the amiodarone itself can kind of act like thyroid hormone, or potentially, how could it act as, what do you think it would cause hypothyroidism potentially? Well, it triggers off the pituitary, right? And it's saying, hey, we have enough thyroid hormone around here. We don't need to release any TSH. What could that do? May not stimulate the thyroid enough, right? So you can actually see in some cases hyperthyroidism due to the effect of the drug, or you can see hypothyroidism, right? So it's one of those things that may seem kind of counterintuitive. Well, why can't it cause both? Well, that kind of makes sense if you know that it kind of looks and is an analog of thyroxine, right? And then, of course, anytime you're mixing different antiarrhythmic medications together, you're always going to see some potential for toxicity, mainly developing other arrhythmias. So be careful anytime you're mixing this with like digoxin, flecainide, phenytoin, anything like that. Okay. Another drug, kind of a newer one we're seeing used that kind of lacks a lot of those toxicities, those kind of chronic toxicities we see with amiodarone, is going to be difetilide or Ticocin. And so again, this is just a pure, potent potassium channel blocker, okay? And again, used for maintaining normal rhythm in patients with AFib. So again, this is another form of rhythm control rather than just rate control. And again, this is actually one of those ones that has a pretty strict restrictions around it to make sure that not just anyone's going to be prescribing this, right? So unless you have specialty training in dealing with this drug and determining who's a good candidate for it, and make sure you're monitoring them appropriately, you don't even have access to this drug, right? So this is mainly can be maintained by your cardiology practitioners there. But the biggest thing is anytime you're extending that QT interval, what do you run the risk of? Torsades, right? So again, this is a big one because it's just blocking potassium channels. You got to watch out, and they can actually cause torsades. We'll talk about the treatment for that in just a second here, but just note that. Again, you have to monitor EKGs. You have to monitor electrolytes very carefully, right? So again, if the magnesium gets off, that can lead to worsened arrhythmias. If your potassium is getting off, that can lead to worsened arrhythmias. So you have to really monitor the BMP in addition to the EKG. Okay, make sure to monitor for kidney function as well, because this one's eliminated in the kidney. So if you are monitoring a patient over time and say you neglect to look at their serum creatinine, what you can see is that, okay, well, things are going fine, they're being treated well, and all of a sudden as their kidney function starts to dip down, levels of the drug are going to climb up, and that's when you can see them develop that torsades. Okay, so again, be very careful with this medication if you ever see someone on it. Be careful when you're either prescribing new drugs on top of that. Imagine if you had someone who had, say AFib and CHF, and then all of a sudden they were coming in, they're edematous, and you want to prescribe them Lasix, right? What is that going to do to this medication? What do you think? So Lasix, furosemide, what's it going to do to electrolytes? going to drop your magnesium, it's going to drop your potassium. All of a sudden that can aggravate this medication. All of a sudden you can see potentially arrhythmias develop here, right? So you've got to monitor these things and think about how the drugs you're adding on you'll be interacting with. It's not just CYP interactions you have to worry about, it's all the other actual physiologic action these drugs are having, okay? That's again why I stress so much which ones are going to raise potassium, which ones are going to lower potassium, because clinically it really does matter, because you screw up potassium, guess what? You can kill somebody. When we do a lethal injection on inmates, what's the last drug they get? Potassium chloride. That will stop the heart if you give too much potassium, if too much around. So again, be very careful whenever you're doing things that are going to be monitoring or be affecting potassium. Okay. Again, I'm going really dark these days. Lethal injections and overdoses. Oh my gosh. I was on call last night for the poison center, so maybe that's something to do with it. I was dealing with a couple strange cases. Actually, I'll bring it up with the case I dealt with last night. Anyway, the one beta blocker that kind of fits into the class 3 category is going to be sotalol. Sotalol itself actually has some potassium blocking activity here. So again, sotalol is not a good drug to be used as an antihypertensive or being used for angina due to this potassium channel blockade here, right? So again, this is primarily going to be used as an antiarrhythmic, and it's going to fit into that same category as amiodarone and dofetilide there. Okay, just note it's still going to have the beta blocking activity, but in addition to that, it's going to block the potassium efflux and prolong the QTc there. Okay, good for either atrial arrhythmias here or potentially for ventricular arrhythmias as well due to that potassium channel blockade. And again, sotalol itself being a non-selective beta blocker, you do want to worry about bronchospasm, and then you have to again worry about that torsades. Yes, ma'am. What did you say it wasn't good for? Good for like hypertension, right? So I probably wouldn't want to manage a patient with hypertension by itself just with sotalol, because again, I have to worry about the QT monitoring and all that kind of sort of thing. Like if I could use something that's a little bit more, more specific just to the beta receptors, like metoprolol, it's going to be a lot better than trying to use something like this. Right. Okay, and then the last group we have here is going to be our calcium channel blockers. Now, which calcium channel blockers do you think I'm talking about here? Non-dihydropyridines, right? So this is specifically which two drugs? Verapamil and diltiazem, right? So these are going to be very good. These kind of fit the same sort of clinical actions as you would think of as the class 2s or the beta blockers. These are going to be good for supraventricular arrhythmias. Okay, these are not going to be good for arrhythmias, kind of developing within the ventricles themselves. Okay. Again, they're going to be blocking the AV nodal conduction. They're going to be blocking contractility, slowing down that conduction from the atria to the ventricles. That's why we like them for those indications. Okay. Again, what do you have to worry about with like verapamil and diltiazem when it comes to things like drug interactions? What do? They bind to CYP3A4. Okay, so they bind to CYP3A4. What do they do to CYP3A4? They inhibit it, right? If you had to guess, if I'm asking about a drug interaction, just to guess, you can always say, oh, they inhibit CYP3A4. You'll probably be right 50% of the time that I answer that question, right? But again, that's because that's the most common thing you're going to run into. But yes, remember, verapamil and diltiazem both inhibit CYP3A4. They're also substrates of CYP3A4, so you have to be careful mixing these with other substrates of that, right? So again, beta blockers typically don't have to worry about that sort of interaction, which is good from that standpoint. Okay, so all little things you have to consider before prescribing medications. All right. Again, as I mentioned, SVTs typically where these are going to be used to help kind of control the heart rate, try to get the rhythm under control there. Again, AFib's another big one. This is another form of rate control. Rather than getting the patient back in a normal sinus rhythm, you're just slowing things down, so that way the ventricles are getting not hammered so quickly that they can't really pump all that efficiently. Okay, that's the thing we're really worried about with those patients there. And again, avoid if patients are in specifically a ventricular arrhythmia, or if they have any issues, with having, a negative inotrope is going to be really poor for them due to the cardiac output issues. Be careful with these drugs from that standpoint. Okay, and then a couple of miscellaneous agents we have here. So we have, we'll talk about adenosine, digoxin again. Remember we talked about digoxin, which other case? What other indication? That's right, CHF. I'm so glad you all remembered that. And then magnesium is the last drug we'll talk about. So adenosine, anyone ever given adenosine? What's it look like when you give adenosine? Scary. Scary. Why is it scary? Stops the heart. How cool is that? When you stop the heart for like a split second, and hopefully get them back into a good rhythm. Actually, as I was going to mention the case we had, I was consulted on last night about this. But basically what adenosine does, if you can think about adenosine, it's kind of like, and it works in the CNS just like it does on the heart, kind of acts like on the brakes on the system, right? So it kind of is like if you think about GABA as being kind of like the normal brake pedal on your car, you can think about like adenosine as like the e-brake or something, right? So you really need to stop something, like adenosine can do it. Okay, same thing for the heart. Here's what I think about it as. It's going to hyperpolarize these cells very hard, and then has such a quick half-life, the drug dissipates very quickly, and then the heart can start to beat again, right? So again, this would be good, and the primary thing you're going to see this used for is for SVT. For supraventricular tachycardia, this is the main drug you're going to go to first line. 9 times out of 10, I would say. At least in the ER is what you're going to be doing first. And again, look at the half-life, 10 seconds. So that means after 10 seconds, you got 50% of the drug going after another 10 seconds, only 25% of the drug. It goes away very, very quickly. So it's good because you don't want it to stick around forever. Because if you did that, then the heart would just be done for good, right? So it would not beat at all at that point. So that's no great. So again, it's going to stop the heart. Usually you're going to have a continuous EKG on the patient, so you can monitor for this. Or in the SVT, you see them tacking away, you know, and then all of a sudden you give the drug, heart stop for a second, and then hopefully it'll come back and sinus rhythm. Sometimes you have to give them a bigger dose, you know, repeated doses to get them into that rhythm. But it's very, very cool if you ever get a chance to see that on rotation. Give it yourself. The big thing to note with this drug is that the administration is super, super important, right? So how you give this will dictate how effective the drug is going to be. Specifically, because it has a half-life, it's very, very short. And again, you're oftentimes going to be given this in, do you think a peripheral or central IV? Think about a typical patient being rushed to the ER, complaining of chest pain, it's palpitations, you get get the monitor on there and tacking away at say 160, 180. They're going to have a a nice central line being placed in the meantime. They're going to have a peripheral IV placed, right? So you're thinking peripheral IV, so again, maybe going to the arm most commonly. It takes time for that drug, when you push that drug, to get from the arm out to the venous system back into the heart, where it's actually going to have its mechanism of action, right? So again, if you're pushing that nice and leisurely and just taking your time over a couple of minutes, guess where that drug's going to be? It's gone. It's metabolized, right? So what we have to do is give it very, very quickly. And so what we end up doing is we have this nice kind of like, a three-way stopcock. Everyone familiar with a three-way stopcock from your chemistry days, right? Everyone played with those before? Basically what we got to do is we have to set one of those up with the drug on it. One end's hooked up to the patient, the other one has a saline flush on it. So that way we can like push the drug super fast, push the saline behind it, and get it back to the heart as soon as we can. Oftentimes, if you give this incorrectly or too slow, you're going to find the drug is dissipated by the time it gets to the heart. You say, well, it's not ineffective. It didn't work. Well, no, maybe the drug just never got there. So that's why oftentimes, administration can be just as important as the drug you're using to treat the patient. So, and then sometimes they'll try to increase the dose. And by the time they increase the dose, then enough of it gets there to actually be effective. But if you give it right the first time, oftentimes you don't need a second dose. So anyway, so the big place you're going to see this for paroxysmal supraventricular tachycardia, occasionally for Wolff-Parkinson-White when you run into those patients. And as I mentioned, stopping the heart for a second does not feel good for the patient, right? So they end up developing a lot of flushings related to this, a lot of shortness of breath, and they describe this impending sense of doom. Is actually, that's like in the literature, like it's kind of the package insert, they describe it as an impending sense of doom. And I was like, wow, it's kind of interesting. You can term it just that way. But yeah, imagine if you stop my heart, I'd probably feel pretty bad for a second too. Like, yep, this heartbeat should come back. Otherwise, not any good. So anywho, adenosine, very cool drug, very good chance to give, very good. The case I dealt with last night was interesting because it was a patient who was an older guy, had a host of diabetes, hypertension, hyperlipidemia, blah blah blah. Got prescribed clonazepam. Does anyone know what kind of drug that is? It's a benzodiazepine, usually either like used for seizures or anxiety. It's a GABAergic kind of drug, so it kind of slows down the CNS. And basically, the doc was calling me up because they said, hey, this guy, his his roommates thought he wanted to kill himself, so they went ahead and called 911. Police came out, they Baker acted the guy, brought him in. So the guy is supposedly overdosed on this benzo, which normally should make you pretty sleepy. Maybe if you find the patient, unconscious, that would be pretty consistent. But the doc was like, yeah, this guy's, heart rate was like in the 160s, 170s, just tacking away, couldn't see a P wave, so called SVT. And so basically what they were trying to figure out was like, well, can clonazepam cause SVT? And so we had to kind of go through and be, okay, well, what else is going on here? To go through his medication list, see if anything could be interacting here. Basically kind of figure out, no, it tended to just be kind of an incidental finding. Who knows, maybe the stress of getting arrested and placed under Baker Act. The guy's like, I wasn't trying to commit suicide. I just moved my pills from one place to another, and roommates thought it was all gone. He was worried about them stealing it in the first place. So anyway, so very complicated case. Oftentimes, you have to play detective when you're kind of doing these consultant type of work here. But they gave adenosine and were able to break the patient back into a normal sinus rhythm, and then he was good to go from that standpoint. Anyway. But next up, we have digoxin. Very frequently, we will use it more for the CHF aspects of it. Remember that neurohormonal sort of effects they have there. Back in the day, it used to be used more for AFib, for control of that. You're starting to see that it can be used less commonly. But if you had a patient with AFib and CHF, this could be a very good drug for them in those cases there. Anyone remember the mechanism for digoxin? inhibits that sodium-potassium pump. Remember that? So again, that's where you're seeing increased calcium levels inside of the heart due to that kind of secondary effects with that. That's what causes that increase in contractility. Why we thought we liked that for CHF for a while. But again, by inhibiting that sodium-potassium pump, it kind of takes longer to get back to resting membrane potential, and so that's why it can kind of slow down the heart in terms of when you have a patient with AFib. Again, be very careful with digoxin as far as monitoring for things like electrolytes. You got to make sure potassium's in range. You got to make sure the magnesium is good. Got to monitor renal function. It can be a very dangerous drug, and this is one of those ones you have to monitor with therapeutic drug monitoring. You got to monitor those levels because again, it's narrow therapeutic index. Again, be careful if you're ever mixing this with beta blockers or calcium channel blockers, because again, that is going to worsen the bradycardic sort of effects there, the negative chronotropic effects, and so you can put your patient into a pretty bad situation from that standpoint. Okay. Remember the interesting side effect you see with digoxin levels are too high, what it does to the vision? Xanthopsia, yeah, you get that yellowing of the vision, that yellow-green kind of halos around lights. That's kind of the classic sort of digoxin side effect you think about, right? Anyway, and then finally we have magnesium. What do we use magnesium for? Torsades. Yeah, we're just going to talk about magnesium a little bit later in the pulmonary section. But yeah, magnesium is going to be typically used for torsades. This is the drug of choice for that. And so essentially, it kind of acts like the body's natural calcium channel blocker, so to speak. Kind of think about it like that. But basically, it's going to be able to interrupt that torsades and hopefully get them back to a normal rhythm. But typically, give pretty big doses, IV. Going to push that, and sometimes it'll be on a continuous infusion afterwards, but usually that first dose is going to be generally pretty good. Big things to worry about though with magnesium when you're giving big doses quickly is going to cause hypotension. It causes a lot of flushing, a lot of vasodilation occurring there, so you typically want to give it with fluids, because again, when you cause the vessels to dilate, you got to fill it up with something, otherwise the pressure is going to drop. So you typically give it with a liter or so of saline in order to make sure that the patient remains intravascularly repleted. And that's it for the antiarrhythmics. Any questions on those? Yes, ma'am.
For adenosine, is it contraindicated for WPW?
For adenosine? Not necessarily. In some cases, you may use it for that. I have to go back and double check, but the main thing you're going to see is going to be for SVT. That's the most common thing you're going to see that used for. Yeah, so we can talk about it afterwards, but again, just think SVT as being like the main place you're going to see adenosine being used for. You can go back and look at the notes there. Yeah. Any other questions? Go back and clarify that. No? All right, so let's move on to the next section.